So our first, thanks for the invitation. Hello, everybody. I'm very glad to join. So I will talk to, I understood that we have an issue with time, so I will be maybe a little bit fast. The topic is pulsatile tinnitus. And we gained some experience recently, and I think it's an interesting topic because it's a little bit innovative. So we did this work with a bunch of colleagues, and so you have to work with ENT surgeon. You need their expertise, and at the same time, we also need the expertise of imaging. So what is pulsatile tinnitus? You know this. It's the perception of a sound that does not originate from a source external to the individual's body. Can be subjective or objective, and we have an identifiable cause in 70% of the cases. So why? Because I think it's a relatively new topic for interventional neuroradiology, although we did cases years ago, but now we gain more experience, it's more interesting. You can help a bunch of patients with this technique, and finally, it's interesting to investigate. How many patients? Not that much. You see that pulsatile tinnitus are only 4% of all tinnitus. But probably you have some patients in your institution that could be treated with this technique, and it's probably interesting to know. So we'll start with a case. This is not exactly what will interest us today, but this is a case of a patient. She's a 53-year-old female patient with a siphon aneurysm, internal carotid artery siphon. And I did a flow diverter procedure in February 2020. The patient was okay, but she complained of pulsatile tinnitus at 1 year during the follow-up. So I saw her, and she said, since the procedure, I have this breath in my ear, and this I cannot sleep and everything, etc. I review the procedure. I saw nothing very special. Maybe you can see her. There's some. You see the arrow. There's some spasm in the internal carotid artery. But when I did the follow-up, I saw that there was a dissection, a iatrogenic dissection of the internal carotid artery. And when I spoke with the patient, she said, yes, the evening after the treatment, I got this pulsation in my head. So it was obviously related to the procedure. And I decided to treat the patient with stents. In this case, I have to use coronary stent because it was only 4 millimeter in diameter, so it was not regular carotid stenting. And after treatment, the patient went very well. So we have confirmation that this was the right diagnosis, and the patient was happy with his treatment. So I will start with some non-specific data. So this, just to remind you that you have to do a general examination of the patient. You have to look for blood pressure. You have to look for anemia, arrhythmia, all these things. But you know this. You have to ask the ENT to do local examination, and we need some lab examination and audiological examination. So we see the ENT, and he will explain what kind of pulsatile tinnitus we have. Then you ask some questions to the patient. Is it permanent? Is it on one side, both sides? Does it stop under manual compression? This is very important because then you know that this is something related to a vessel in the neck. Does it come with when the patient is stand up or in decubitus? Is it associated with other symptoms of here, especially vertigo, of this kind of symptom? And then you can have a score of tinnitus, you know, if it's a severe tinnitus or less severe tinnitus, and then you will know what you do with the treatment. So what is it? So we can have from patient dissection and very debilitating pulsatile tinnitus, but the main point, in my opinion, is the vein. And with the vein, we have to look for dehiscence of the bone, so a focal defect in the cortical bone in contact with the vein. And then you see you have this contact between the vein and the ear structures, and you see if there is a communication, pressure communication between the two structures. It can be jugular bulb related to inner ear dehiscence, or jugular bulb related to middle ear dehiscence. When it's middle ear dehiscence, it's only pulsatile tinnitus, or is the main symptom. If we have more symptoms like vertigo or deafness or other symptoms like this, it's related to inner ear dehiscence, so it's a different disease. Then we have, this is dehiscence, and then we have abnormal mechanical somatosome production due to transverse sinus stenosis. So we start with this case. It's 59-year-old patient with many reform attacks for several years, and acute onset of vertigo and pulsatile tinnitus during exertion or head position. You have to remember that these conditions are very problematic for the patient, because as soon as the patient is exercising, sometimes it's only changing position, sometimes it's between when he cough or when he laugh, so the patient has vertigo. In this case, he had deafness. We did the acoustic evoked and myogenic evoked potential. It was normal. And this is CT evaluation. So you need high resolution CT, and you see the dehiscence between the jugular vein and the vestibular aqueduct. And vestibular aqueduct is not dilated, as you can see. So this is the vein. So we decided to go, because we want to stop the communication of pressure between the vein and the structure of the ear. And so we go for a procedure with placement of stent and placement of coils inside of this venous pouch, like kind of treatment of aneurysm with stent and coils inside the sac. So in this case, we have pulsatile tinnitus and we have other symptoms. This is the dehiscence between jugular vein and vestibular aqueduct, as you can see. The jugular bulb is related to inner ear dehiscence. We do the treatment with endovascular stent and coils, and we occlude this the portion of this high-reading jugular vein in communication with the ear. The patient has excellent improvement. He returned to normal life. We have a second case. It's a 46-year-old patient with daily onset of mania attacks, worsening in right lateral decubitus, and the pulsatile tinnitus is increasing during exertion. Again, very debilitating, very problematic for the patient. In this case, we have also a dehiscence of the jugular bulb and communication with the vestibular aqueduct. And in this case, the vestibular aqueduct is dilated. So it's not the same story. And in this case, same diagnostic, pulsatile tinnitus with inner ear symptoms. We have dehiscence between jugular vein and vestibular aqueduct. We have same disease, but we have hyperpressure, increased pressure in the vestibular aqueduct. So in this case, if you do only stenting and coiling, it's not enough. It was better in this case to operate the patient. So in this case, we can the surgeon can decompress the structure of the ear, and it's better for the patient because it's not only a contact and pressure, it's also that there is hyperpression and dilatation of the vestibular aqueduct. Third case is a 31-year-old patient with vertigo during exertion or attention sloughing. Again, very disturbing for the patient. He has a nystagmus. The video will not come, but you know nystagmus with Valsalva. So as soon as he's doing the maneuver of Valsalva, he has a nystagmus. And this is the CT. You can see the jugular bulb in blue, vestibular aqueduct in black. And again, this case, not related to the symptom, but related to the lack of dilatation of the vestibular aqueduct. This case can be treated with stent and coil. And so we put a stent inside the jugular bulb and some coils inside the pouch. And you can see very clearly on the CT scan, the image on the left of your screen. You can see the stent, you can see the coils inside the venous pouch. Another case, this is a patient with pulsatile tinnitus, no inner ear symptoms, so only pulsatile tinnitus. So this is this case, sorry, I was just commenting about this case. So this case was a patient with pulsatile tinnitus and no inner ear symptoms. The distance between jugular vein and vestibular aqueduct not dilated. So this is not related to inner ear, but related to middle ear. And we can treat the patient with stent and coils with excellent improvement. So we have two options for these patients. You can treat them by endovascular stent and coils or by surgery. And the surgeon can put some hydroxyapatite to separate the vein and the structure of the ear and do a decompression in case of dilatation of vestibular aqueduct. A new case, a 45-year-old patient with right side disabling exercise pulsatile with dizziness and vertigo. He has hyperresponsiveness on the auditory and vestibular test, and he has hearing loss. So this is a special case. This is a very specific case because in this case we find again the dehiscence, meaning a focal defect of the cortical bone, but this time it's between the superior petrosal sinus and the superior semicircular canal. So you can see in the middle picture, you can see this dehiscence above the superior canal. You can see the petrosal sinus. You can see also in the MR on the right. So this is how we understood it. So you have the semicircular canal, superior. We have the red dot is the dehiscence. And so the pressure is propagating from the vein to the superior semicircular canal. And the patient has symptoms related to raised pressure in the vein. So we discussed how to treat this patient. Obviously, we want to change the pressure regimen inside the superior petrosal sinus. There was two possibility by endovascular treatment. So we can place a stent or we can place coils. I decided to go, this is the pressure. I decided to go for stent. I said that with a stent we can preserve the patency of the vein, and if not, the stent will thrombose, and then we'll have the same result that we can do with coils. So this is the procedure. You can see we went to the inferior petrosal sinus for the cavernous sinus, and then to the superior petrosal sinus and place two stents inside the superior petrosal sinus. And this case, we have pulsatile tinnitus. We have symptoms of the inner ear. This is the jugular bulb related inner ear dehiscence between superior semicircular canal and superior petrosal sinus. It's a minor disease. We did stenting of superior petrosal sinus, and it was the first case that was done by endovascular treatment. The patient went very well with pulsating tinnitus that resolved. Dizziness and vertigo almost disappeared. The patient went back to work. So the patient didn't work for years. And also induced nystagmus by sound and vibration disappeared. And the superior petrosal sinus stay patent, although we don't care very much, but it stay patent, and I control it with by going inside the superior petrosal sinus with a microcatheter and did an injection and see that the vein was patent. We have difficult cases. Sometimes we have several potential cases for causes for the disease, and we don't know exactly which one is responsible. This is an ambiguous case. We have a 50-year-old patient with high score pulsatile tinnitus, no vestibular symptoms. You see that there is both in this patient right large granulation of papioni, and on the same side, you can see on the CT scan and on the MR. Unfortunately, I cannot show you with my device anyway. And on the same side, the patient had high riding tubular bulb with dehiscence. So he has two different causes. So we discussed the case and we decided to go for the treatment of the stenosis, related to the granulation of papioni. There was no difference in the pressure, the vein, before and after the granulation, but we don't care. It's not a hemodynamic problem. It's a problem of sound vibration. The patient was under dual antiplatelet therapy. Some colleagues will have only mono antiplatelet therapy, which can be discussed. I think in the end, probably it's enough because not exactly the same problem as in the artery. So I placed a 10 millimeter balloon expandable stent. And with this treatment, we have a decrease of 2/3 of the intensity of the pulsatile tinnitus. Just after the procedure, we have transient worsening related to hyperpression in the inner ear structures. So pulsatile tinnitus, no inner ear symptoms in this case, two possible causes. We decided to go for the stenosis first, and the patient was significantly improved. But you never know exactly. We follow the patient, and if needed, we can add a new procedure to this patient. This is a case of stenosis before and after stent placement. So, this is a problem. Problem you see some dehiscence between the vein and the structure of the ear. Can be inner ear, can be middle ear, depends on the symptoms. To understand this, we need some tools, but I will go very fast to this. You know that we need high resolution CT, and sometime we can use, like you see this color picture, fusion of MR and CT. You need to understand what is a high rating jugular bulb. What you see this picture, you can see that part of the jugular bulb is too high, and there are different definitions for this. But I go fast to this. These are only definition. What is the vestibular duct for some students that don't remember? You see, this is vestibular duct. This is a canal where you can find endolymphatic sac and endolymphatic duct. You can see it on the CT, normal vestibular aqueduct, enlarged vestibular aqueduct, and in the end, some information about dehiscence and dehiscence of the bone in contact with the vein. Dehiscence is dehiscence of the sigmoid plate, but you can find this easily and understand what is the dehiscence. In this case, the bulb is free to produce into the middle ear cavity and is then known as dehiscent jugular bulb. This is what you see if you look at the tympanum. Not always, but if the vein is high, you can see the vein behind the tympanum. And so this is usually the expertise of the ENT to look at the ear and see. So this is the main message. Now we go to other causes. Other causes, you find it very simple. It's the same story. You can have diverticulum of the vein. So you can see this pouch of the vein, and usually it's easy to treat. It's often related to stenosis. So you can have transverse sinus stenosis and the diverticulum. There is a relationship between the two. Easy to treat with coils. We go fast with this. We can have emissary veins, sigmoid sinus dehiscence. The point is, you have a patient with pulsatile tinnitus, usually very debilitating, and we have CT. On the CT, we have a dehiscence, but you don't know exactly, like the case that I showed you. Sometimes you have several causes. You don't know exactly if the procedure will help the patient. So you have, again, a bunch of arguments that will lead you to think that there is a relationship between these symptoms and the dehiscence. You can find this in the literature, this paper from Park, the paper from Friedman, when they describe the relationship with this anomaly of the bone, anomaly of the vein, and the symptoms. And you see that it's much more frequent to have symptoms when you have dehiscence and when you have vein, high-rating jugular vein. Finally, the disparity of symptoms is final demonstration, but you have to know something about the other cause of pulsatile tinnitus. They are very numerous. We have very lot of different diagnoses for pulsatile tinnitus. Some are very rare. An interesting approach is to try to reproduce the perception of the patient. So if you're able to modelize the sound and see what is the relation between the turbulence of the vein and the sound that can be produced, and you make it here to the patient, and you see if the patient is hearing the same sound. And now you have something more to think that there's a relationship between the anomaly and the symptoms. So many other cases. So we talk about the veins. We have causes that are vascular tumoral. Some are unclear. We have autospongiosis. I have a list. I will send you the presentation. You can see a quick description of each situation. For example, that you can have arterial or arteriovenous communication, but you can have this dissection we saw, dural fistula, aberrant ICA, and persistent of the stapedian artery. So many causes, and you have to know a little bit about this in order to understand what is related to the vein and what is not. So thank you. I will send you the presentation, and you can see the different causes with some tumorals and some other causes. I hope you can hear me. Hello?
Francis, we hear you.
Yes, we hear you.
Просто спасибо большое. Это очень, на самом деле интересно.
Thank you so much. It's a new, interesting approach when we look at the pulsating tinnitus and the various pathologies and deformities that can be caused